Thank you. Good afternoon, everyone. So we're going to talk about the next generation. This is my disclosure slide. So the available valves that are available now to us, you are all aware of them, primarily the Melody valve and the Edwards valve, and you heard through the course a lot about these two valves, so I'm not going to discuss them at all. There are some similarities and differences between them though. However, both of them are suited primarily for patients with conduits or bioprosthetic valves, although we have seen some implantation in native outflow tract. The problem, 15 to 20% only of the patients status post-liturgy flow repair are candidates for these two valves, and that leaves a large percentage of our patients with native outflow tract. There are few valves on the horizon. The first one that has probably the largest experience is the venous P valve. This is a 19-hole self-expandable multi-level supportive frame, integrated unidirectional tri-leaflet porcine pericardial tissue valve. The entire stent is covered except the distal cells that will be anchored towards the bifurcation of the PAs. The stent valve is a moderately radio-opaque and it has a small delivery system. And this is the valve as it stands. So these are the distal cells that are uncovered by the pericardium. And this is another view. So this part here will be anchored towards the bifurcation. This is towards the inflow, and this is the straight part of the bioprosthesis where the valve is. The valve comes in different sizes. Currently, the manufacturer is working at 16 millimeter in diameter all the way up to 36 millimeter in diameter, and the straight portion is variable from 2 to 3 centimeter. This is the delivery system, 14 to 22 French. This is the crimper, self-expandable, so you have to crimp it under ice and then load it into the delivery system. So these are the slides. I don't want to go in details to save time. Just to show you an example, this is a lady, 31 years of age, status post-liturgy fellow repair, 43 kilogram, had 2 surgeries, and basically has severe pulmonary insufficiency. This is her transthoracic echoes by our excellent echocardiographer Cheeling. The right ventricle is large, and this is severe pulmonary insufficiency, as you see it by the echo. So this is the actual case. Took her to the cath lab. This is first in human in May 2013. I did 2 cases in Shanghai. So there is the outflow tract here, severe PR, RPA, LPA and RPA almost wide open. This is the lateral projection. Basically, it's a self-expandable valve, does not require any pre-stenting, similar to the other 2 valves. Still, we do coronary injection to make sure that the coronaries are far from the outflow tract, like shown in this picture. There is the valve is coming over this super stiff guide wire. Another catheter from the contralateral femoral vein for control angios during positioning. You can deploy more than half of it, and then if you're not happy with the position, you can recapture most of it or move it. And then finally, once you are happy with the position, basically you can release it. So the handle is a controlled release. You can see it, very nice position there towards the bifurcation. There are radio-opaque markers to show you the valve. You can see them right there. And then finally, the release of the valve in the position. Then you repeat final angio. You can see that there is no insufficiency at all. The valve works really well. And this is intracardiac echo I did during the implantation. You can see the valve leaflets very nicely and no pulmonary insufficiency at all. This is a quick cine shot to show you the radio opacity of the valve. Chest X-ray the following day again shows the valve frame. So this is the venous P valve. Where do we stand currently? There is an application for a CE mark study in Europe led by SHAC and a few other operators in Europe. So far, there's approximately 50 cases done worldwide, most of them in China. They're doing the primary study in China for approval by the Chinese regulatory authorities. A few cases have been done in Thailand by Waracan, and a few cases in India by Siva Kumar, and Shaq did already on compassionate basis in London, I think up to 7 cases, and he can correct me if I am wrong. And we are awaiting approval myself in Doha, which I am hopeful within the next few weeks we will receive this approval. The other valves that are available for native outflow tract, the Medtronic valve and the BeiGene Med-Zenith PT valve stent. The Medtronic valve, porcine pericardial tissue valve, and I think you saw the slides earlier when John presented the information. It's a tissue valve mounted on self-expandable frame, coil loading catheter, one size 25-inch loading funnel to collapse the valve prior to sheathing. And as he mentioned earlier, there is a trial ongoing, 3 sites, Columbus, Boston, as well as Toronto. The second valve available for or being evaluated in the preclinical status is the BeiGene Med-Zenith PT valve stent. Self-expandable nitinol frame lined with porcine pericardium, 3 porcine pericardial valves sizes 20, 23, and 26 millimeter, 5 frame dimensions with variable widths and lengths. This is the unique delivery system, 18-French controlled release handle, somewhat similar to the venous P valve. So to conclude, the new venous P valve is self-expandable nitinol valve designed for patients with status post transannular patch repair. The new valve is available in sizes ranging from 16 to 36 millimeter, thus appropriate for most patients with large RVOTs. Clinical trials will commence shortly in Europe, Qatar, and Asia. And other valves, primarily the Medtronic and the BeiGene Zenith valve, are also being developed for that. I would like to thank Chilling for his excellent studies that he did all the work for the preclinical data, and the physicians from Zhangjiang Hospital in Shanghai for the data and information, and where we did the first-in-man using the venous P valve, and of course John and Mr. Larry Meng for providing me information on the Medtronic valve and the BeiGene valve. Thank you.